So good evening, everybody. From CCI, Chess Council of India. I am Dr. Abhishek Prajapati, pulmonologist from Gujarat. So today we are going to have a discussion on pharmacotherapy of in ARDS, evidence, innovations, and expert insights. So this is an ARDS series by CCI, and we have already done the the three parts of it, and today is the fourth part. As all we know that ARDS is a syndrome. It's not a one specific disease, and it has many reasons we have already understood in the previous webinars. And as far as pharmacotherapy is concerned, there is very less thing we know, and we have very limited evidence. So in present era, what pharmacotherapy is useful, whether any evidence of any advancement available, and in today's time, which therapies is okay to go ahead and to have a better outcome in ARDS. For this, we have a very esteemed panel of four pulmonologists of India. We have a uh, Dr. Govind Desai. He is a pulmonologist, consult pulmonologist from Hubli. We have Dr. Swadip Mishra, a pulmonologist from Bhubaneswar. Dr. Himanshu Pophale, sir, a pulmonologist from Pune, and Dr. Sindhura K from Chennai. Welcome you all. And with this, we will start with the first. We will have two lectures. First, we will have a lecture of Dr. Govind Desai. He will be speaking on past, present, and possible futures of pharmacotherapy in ARDS, followed by a talk of Dr. Himanshu sir. He will be talking on corticosteroids in ARDS. So over to you, Dr. Govind.
At the outset, I would like to thank the Chess Council of India for giving this wonderful opportunity to discuss about the recent pharmacotherapeutic managements in ARDS. So I'm going to start the session with the initial talk, that is the past, present, and the future of ARDS therapeutics. I'm Dr. Govind Desai, consultant clinical and interventional pulmonologist from HCG Suchirayu Hospital, Hubli. So the next 10 minutes, I'm going to discuss about a very simple thing, that is, what were the past pharmacotherapeutics which were used in the management of ARDS, the present pharmacotherapeutics, and the future pharmacotherapeutics. So a lot of things are in actually the gray area. It's neither the black or the white. We neither know that it's too supportive, nor we do have evidence to say that there is no support at all. But we have been using a lot of medications in the management of ARDS other than the NIV and the non-invasive ventilation, as well as the invasive ventilation. So I'm going to discuss about the pharmacotherapeutics and which are available in the past, the present, and the future. So coming to the past, we had the recombinant activated protein C. Now the molecule name was Sigris, which was an anticoagulant, anti-inflammatory, and a fibrinolytic property. It was first approved in 2001. And a lot of people, I think, over here who are listening this might have used it as well. But what happened is that the initial enthusiasm following the publication of the PROVESS trial, which was the landmark trial in the initiation of this Zigris molecule, was tempered significantly with subsequent studies showing a lack of efficacy of activated protein C and an increased incidence of bleeding in the general clinical use. So I'm just outlining few of these trials which were available: the PROVESS trial, the ADDRESS trial, the RESOLVE trial, the ENHANCE trial. What all of them showed was the mortality chances were very high when compared to that of a treatment arm. So we can see in all these things that initially the patient showed very good response, but over a period of the next 28 days, there were high chances of serious bleeding, increased particularly in surgical cases of ARDS. Hence, these are few other studies which were showing that there was an increased mortality cases as much as 45% and serious bleeding as much as in 10% of the cases. So a lot of time this molecule, that is drotrecogin alpha, was also used with heparin, but did not show much great use, and hence it was withdrawn from the market. Then came the statins. Simvastatin was one molecule with 80 milligrams, and it was compared with placebo once daily for maximum 28 days. It did not show any improvement in the 28-day mortality, non-pulmonary origin, organ failure free days, or ventilator free days, although it had a very acceptable safety profile. Rosuvastatin 40 mg loading dose and for 20 mg maintenance dose or placebo once daily until the third day after discharge from the ICU. The study day 28 hospital discharge or the death did not show any great significance, particularly no significant reduction in the hospital mortality, nor improved clinical outcomes. So hence, even statins were withdrawn from the ARDS management and most of the trials were prematurely stopped. Then came the vitamin D. A single enteral dose of 540,000 international units of vitamin D was matched with that of the placebo. What was seen was there was no clinical difference in either the patients who were having vitamin D deficiency or those who received cholecalciferol when compared to that of placebo in terms of 90-day mortality and secondary endpoints. Hence, even this did not influence the results, particularly managing the mortality of the cases in particularly ARDS. Then came aspirin. We have seen aspirin quite widely used even in COVID, but none of the studies have significantly shown any reduction in the incidence of ARDS at 7 days point of end. Then came heparin. Again, heparin is used very well in cases of anticoagulation measures, particularly in sepsis and septic shock. But in ARDS, heparin has not shown any significant benefit. Hence, even this is out of the practice in particular ARDS management. Albumin replacement was also tried to be seen and it was compared with the use of crystalloid administration alone. At 28 days and 90 days, there was no significant survival benefit. Salbutamol was again a molecule which was very commonly used either in the form of intravenous infusion of salbutamol or in the form of nebulized salbutamol, that is 5 mg, which was compared with the saline arm. There was a higher 28-day mortality rate in salbutamol group, particularly the IV therapy salbutamol which was used was associated with tachycardia, arrhythmias, and lactic acidosis. This trial was stopped early because it showed no significant improvement in clinical outcomes and also no modification of serum IL-6 and IL-8 levels. Furthermore, ICU-free days were fewer than when salbutamol was given to patients with shock at the time of randomization compared to those with given placebo. Coming on, we all know that ARDS is basically a disequilibrium between the pro and the anti-inflammatory pathways, complement activation, endothelial cell activation. So there are a lot of things where we can try to tweak and try to manage the ARDS. The present management basically is mainly focusing on 4 things, that is neuromuscular blockade, corticosteroids, inhaled pulmonary vasodilators, and antibiotics. Coming to NMBs, cis-atracurium is one of the promising molecules which have been used. It is not associated as much as ICU-acquired weakness that compared to a vecuronium. Cis-atracurium is associated with fewer ICU and ventilator days, suggesting that it may be a preferable neuromuscular blocking agent for patients with ARDS. The Accuracy study and the ROSE study, which are very commonly well known in the critical care, are the 2 studies which have been seen. A strategy of daily awakening or light sedation is known to result in improved outcomes when compared with that of a deep sedation. What was wrong with the Accuracy study was the placebo arm was given a deep sedation as compared to that of a daily awakening, which was commonly practiced. So the ROSE study, which used it, did show that when it was used with that of a comparative placebo arm, there was no significant change. But what has been very important is that group of patients who have severe ARDS, substantial ventilator asynchrony, and refractory hypoxemia, especially with a PaO2 of FiO2 of less than 100 millimeters of Hg. However, its routine use is not recommended. Corticosteroids have been used, be it dexamethasone, be it hydrocortisone, or be it methylprednisolone. In addition, glucocorticoid therapy is harmful in patients with pneumonia, particularly if initiated more than 14 days after ARDS diagnosis. The LACERIS study or the late steroid rescue study has shown that there has been a reduction in mortality, but the overall mortality rate was not decreased, and there was a concerning increase in 60 days and 180-day mortality rate in a subset of patients given steroids more than 2 weeks after the onset of ARDS. So that is a very important take-home message. We have the recovery trial, which was used in COVID-19, particularly use of dexamethasone was associated with a lesser 28-day mortality and also requiring lesser ventilation support. Then we have the inhaled pulmonary vasodilators, be it the prostacyclins or the inhaled nitric oxide. The basic mechanism is that the ventilatory perfusion mismatch, what is happening, and the increased dead space ventilation, what is happening, is tried to be reduced with the use of an inhaled nitric oxide. though we don't have a very significant benefit with either the inhaled nitric oxide or the usage of the prostacyclins. In the future, we have a lot of things. We might get a few of the repurposed drugs which were used in the past, particularly vitamin C, beta agonist. In statins, we have particularly the ulinastatin, which is mainly a data driven by the Chinese group, but we don't have a much of Western data. Then we have the mesenchymal stromal cells and the granulocyte macrocyte colony stimulating factors. A lot of data is yet to come. We also have the endophenotyping and the phenotyping of ARDS, the hypo-inflammatory part and the hyperinflammatory part. Yet, I think we have a lot of things in the box, and probably with time, we need to get into what is in the future for us. And I would now hand over the mic to the next speaker, that is Dr. Himanshu sir. And after that, we'll be having the panel discussion wherein we'll be discussing much more into the deeper aspects of the management of ARDS. Thank you so much.
At the outset, I will like to thank CCI for giving me an opportunity to be a part of this webinar. So, thank you for setting up the pitch for me. Now, I will have a word on role of corticosteroids in ARDS. So, first of all, let me introduce myself. I am Dr. Himanshu Pophale. I am Professor, Head of the Department, Kashibai Navle Medical College, Pune, and private practitioner in Pune. So coming to the main topic. So as we all know that this, on the left side, you can see a normal alveoli, which has a tight epithelial junction, which helps in a good gas exchange within a nearby pulmonary capillary via interstitium. There is a good air-blood barrier. What happens in ARDS? There is an injury or a toxin which stimulates the resident alveolar macrophage, which in turn leads to an inflammatory cascade. Inflammatory cells, cytokines, chemokine, ROS, NETs, protease, etc. They're released. And then there will be damage to the epithelium, impaired endothelium, destruction of the junctions, edema, and then ultimately there will be some amount of fibrosis. So what a corticosteroid does is it inhibits this pathway, the inflammatory cell cytokines and chemokines. So theoretically, this should stop the further damage to the epithelium, endothelium, and further destruction in the junctions and reducing the edema. So what are the potential benefits of the corticosteroid in ARDS? It can reduce inflammation, act as a potent anti-inflammatory agent, helps reducing excessive inflammation, and thereby reducing the alveolar damage, and helps improving the gas exchange across the alveolar capillary membrane. And it also improves the oxygenation. As there is reduction in the inflammation with the use of steroids and decrease in the alveolar damage, this reduction helps in improving the oxygenation, thereby improving the PF ratio. It also reduces the mortality. How? The improved oxygenation helps reducing the requirement of the mechanical ventilation, as steroids help in increasing the ventilator free days. Obviously, if there is a improving in the oxygenation, then we will taper down the ventilator as fast as we can. So, which in turn reduces the mortality. The corticosteroids have been shown to reduce the disease severity scores, namely the multiple organ dysfunction syndrome score and lung injury score. This agent also improve the PF ratio. So for this particular talk, I have selected few very important articles in the past and very near future. So I'll start off with the partly old article of NEJM, Efficacy and Safety of Corticosteroid for Persistent Acute Respiratory Distress Syndrome. Around 180 patients were equally distributed between methylprednisolone and placebo, and completed 180 days of the follow. The corticosteroids improved cardiopulmonary physiology within 3 to 7 days after their initiation and altered the course of ARDS. Treatment with the methylprednisolone increased the number of ventilator-free days, ICU-free days, shock-free days during the first 28 days. The next article I see a very renowned Dr. Professor G.C. Khilnani et al. In Lung India, which was published in 2011, corticosteroids and ARDS. This was a review article which mentions that despite sound physiological basis, corticosteroids have not shown a clear-cut benefit in the management of ARDS. It is clear from the available data that these agents have no role in prevention and late phase of ARDS. However, there is a silver lining in management of the early ARDS using these agents. There is distinct advantages of the corticosteroid in improving organ function score, lung injury score, oxygenation, which results in reduction in the duration of the ventilation requirement and ICU stay. So, and then just a small pre-COVID trial was a Desai ARDS trial by Wheeler et al., which include 277 patients and divided between steroid receiving and placebo, which also states the steroid arm has lower 60 days all-cause mortality rates and more ventilator-free days, which lead the author to conclude that the steroid therapy is beneficial in ARDS. So next is again a recovery trial, which is a very well-known COVID trial in which the patient hospitalized with COVID-19 using dexamethasone resulted in overall 28 days mortality among those who were receiving their either mechanical ventilation or oxygen alone. So this trial doesn't include a full-blown ARDS also. This also include minimal oxygenation patients. So this was, but although this is very helpful in deciding how the steroid works in such type of ARDS. And the most latest is a counterpoint. Should corticosteroid be routine treatment in early ARDS? That suggests a personal approach in which the steroid therapy are given constantly to patient most likely to benefit withheld in patient at higher risk of harm and considered on case-by-case basis. I'll show that table in my next few minutes. Timing of the initiation is very essential. Early ARDS is characterized by a strong pro-inflammatory response, and one would expect that the anti-inflammatory drug must be beneficial at this stage. The corticosteroids have been shown to reduce the disease severity score, namely the multiple organ function syndrome, which is also mentioned in the Kilnani-Sir's trial. So I'll go towards the late. Again, then there is a Meduri et al., which shows that the corticosteroid prolonged use in early ARDS was associated with significant decrease in the ICU mortality. Whereas for the late ARDS, a persistent ARDS at a later stage is characterized by more fibrosis than cellular inflammation. Therefore, corticosteroid is expected to be different. It has been shown that there is significant association between late initiation corticosteroid and failure to improve. So almost 50% failure rate. In ARDS NET trial, in patient with ARDS, corticosteroid use was associated with increased mortality. So late ARDS is most of the time a negative for steroids. This is a very interesting table which gives how strong is the risk of complication from the steroid. I want everyone to take a picture of this slide. This says that the PF ratio less than 200, despite optimal ventilatory management and septic shock and COVID-19 more than 7 days since symptom onset is a very strong indication. If there is a very high risk of complication with the steroid, in that case, do not give the steroids. I think this will be my last slide because I have very limited time. Corticosteroids are potential therapeutic agents which are used in critically ill patients, including ARDS. However, these agents have a number of adverse effects such as hyperglycemia, fluid retention, electrolyte imbalance, pancreatitis, increased infection rate, neuromuscular weakness, GI bleed, etc., which may be important limiting factor on this therapy. However, a close surveillance as described by Meduri et al. And ARDS NET trial recommended to identify the new infection, treat it promptly, as significant number of patients on corticosteroid may develop infection in absence of fever. Along with this, appropriate glycemic control, minimal use of sedation, neuromuscular blockade will further minimize the complication. And also, in clinical epidemiology, an outcome of invasive pulmonary aspergillosis as a complication of respiratory viral infection. Addition of corticosteroid in ARDS due to viral pneumonias may lead to further dangerous invasive pulmonary aspergillosis. So my take will be use it very judiciously when very early ARDS, late ARDS, there is not much benefit. Thank you very much for giving me the opportunity. I will conclude here.
So thanks a lot, Dr. Himanshu sir and Dr. Govind, for a very nice presentation. And you said this was our basics of our today's discussion. So with this of our basic information provided by Dr. Govind and Dr. Himanshu sir, we will start the panel discussion. So the first question to Dr. Govind. So as in pharmacotherapy, the basic thing to manage the patients of ARDS will be a sedation and our relaxants. So with that, we will be starting with the what is the role of neuromuscular blocking agents in treatment of ARDS, and can you summarize the evidence for their use and set your clinical approach, how we should use judiciously and when not to use?
So, good evening, everyone, and good evening to all my fellow panelists and to Abhishek sir as well. So, this question, what we have about the role of neuromuscular blockers in the role of ARDS, has been a very debating one. But we all know that in the case of ARDS, we do use neuromuscular blockers. So, most of the studies, what we have in the literature is based on the use of cis atracurium and atracurium. One of the reason I think which I discussed in my previous presentation as well was that cis atracurium and atracurium are two molecules which basically have a very strong following of Hoffman's degradation. That means it acts as how much as it needs to be acted upon, because the active metabolites which have been broken down from cis atracurium, because they do follow an Hoffman's degradation, do not have any side effects, particularly the critical illness, myopathy, and the neuropathy, which we commonly see or encounter. Now, the second thing regarding the evidence about these neuromuscular blockers is number one, we have two major studies which have been published, and both the studies are quite recent. One is the Accuracy study, and the second one is the Rose study. The Accuracy study compared the use of cis atracurium in cases of ARDS and septic shock with that of particularly the patients of placebo. What it did show is that there was a benefit in cases of mortality, but the drawback which we saw with this study was that most of the cases, the placebo arm which was used did not follow the daily awakenings and the light sedation which we normally follow in our principal and regular things, because we do know that patients who have ARDS who are on ventilator, who we follow basically the daily awakenings as well as whom we follow the principle of light sedation, are being shown to have a better benefit and better off ventilator days and early off to ventilator days. So this was one of the drawback. In the Rose study, they compared those same molecule of cis atracurium with those patients of placebo, but here the daily awakening and the light sedation was followed even in the placebo arm, and that did not show any big mortality benefit. So what does this indicate is basically whether it was the cis atracurium which was giving the benefit, or whether the light awakenings and the daily awakenings or the light sedation was having a better edge, was something of a big picture. But what I can conclude by this is that patients, particularly that subset of the patients who are having a lot of patient ventilator asynchrony, these are, we have some set of patients who are smokers, who are alcoholic, and who end up in ARDS. So these are that subset of patients particularly have a very bad patient ventilator asynchrony. So in this subset of patients, we can see a very good benefit with the use of neuromuscular blockers. So even in my practice, I particularly see that what kind of the patient we are dealing with, and what we basically call as a personalized approach of management. And in that subset of patients, I use it. So the routine use of cis atracurium is not recommended. But in cases where we need for the first 24 hours and 48 hours a proper knockout of the patient with daily awakenings, I think cis atracurium and atracurium have a good role. And that is what even the benefit, even the evidence shows us.
So thanks a lot, Dr. Govind. So you precisely told the exact role. So the point is, cis atracurium or neuromuscular blocking agents are must whenever the patient having a severe ARDS, severe work of breathing. At that time, to have a better patient ventilator synchrony, we need to relax the patient. We need to sedate the patient. And in this set of patients only, for limited period of time, as you mentioned, for 24 to 48 hours, it is the mandatory thing we need to do to have a better outcome. If we don't give these patients this cis-atracurium or neuromuscular blocking agent, we may lose this patient within few hours, right? So this is the point. With this, Dr. Sindhura, now another important aspect of this pharmacotherapy, the sedation. So sedation and analgesia are critical in ARDS management. How do you balance the benefits of deep sedation for lung protective ventilation versus the risk of prolonged sedation? Means which sedative agents we will use and when to use and which are the preferred things and for how much duration we should use this and what are the end targets, how to optimize the sedation in ARDS patient when patient we are ventilating.
So lung protective ventilation is the main concept of what we use in ARDS with the low tidal volumes and the high PEEP. And when you are not giving sedation or when patient is awakening or having a light sedation, then there will be a patient-ventilator interaction. And because of the increased high metabolic demand and increased respiratory drive, patient might be having requirement of high tidal volumes. So when the ventilator asynchrony is there will be double triggering of the active exhalation might be taking place other than being passive because the patient is sedated. So because of all this, there will be collapse of the alveoli, and repeated collapse of the alveoli and hyperventilation leads to lung injury, further lung injury that is called as a ventilator associated lung injury. So there are high chances of happening if you don't sedate the patient who is on ventilator. And the lung healing also will be hampered. So deep sedation is completely required for recruitment of ventilation or recruitment of the alveoli to avoid the ventilator-associated lung injuries that are caused due to patient-ventilator asynchrony. However, deep sedation has its therapeutic modalities, and there is a downside also if you completely sedate the patient. And you should not, till when you have to sedate the patient, you should set up some targets. Like if PaO to FiO2 ratio is less than 200, moderate ARDS, from very low ARDS to moderate, maybe you should be sedating the patients. Once the ratios are improving and patient is getting better, maybe you should be off sedation and all. So there should be some targets for using the sedatives, and it depends on your clinical practice, and no proper guidelines or anything is available to know when to stop, when to start, and how much of sedation is required. There are no proper guidelines on that. But sedation is required, and it needs to be individually decided.
Okay, so anything which agents to be preferred, Dr. Sindhura? Any specific preference over the other agents?
Nothing.
Which agents we should utilize first?
Nothing specific as there, sir. Along with the neuromuscular blocking agents, we can use a mild sedatives.
Okay, so the thing is, whenever we are having a severe ARDS and we need to knock down these patients, the very basic thumb rule of the sedation and relaxation of the patient is we definitely need to have a sedation and analgesia first, and then only we need to give a relaxant. So without sedation or analgesia, relaxant is a crime, right? What we are doing actually without sedation or without sedation or analgesia, when we are giving only relaxant, right, like cis-atracurium, atracurium, means we have relaxed the muscles of the patient, but patient is knowing everything, whatever is happening. Means patient can't breathe. He also knows that he can't breathe, but he cannot do anything. So this is the thumb rule of the sedation and analgesia. We need to definitely go for first sedation, and then and only add we should use relaxing agents. And as far as the yes.
All is usually avoided. Depends on the patient's clinical condition. We can decide on what sedative we want. So.
Yes. So the preferred agents are when the patient is having a mild ARDS, we need to prefer fentanyl, which is a very which is opiate and which gives a sedative and analgesia both effect. And then we may use a midazolam or like benzodiazepine, and then we add our muscle relaxing agent. Preferably atracurium. Cis-atracurium is very not available every time in every place in India. in today's era also. So these are the things whenever the patient is having we don't need so much of sedation. At that time, dexmedetomidine is also a preferred agent. Whenever we want, we don't because it has an advantage of lesser respiratory suppression. So these are the things, and there are some scales like Resmond are scales. We have to titrate the patient consciousness level from -2 to 0 level, and in that level, we have to target the sedation of the patients. Okay, and so now the next question to Dr. Swadip Mishra. Dr. Himanshu sir already discussed very nicely the role of corticosteroids, but again we need to discuss because it is a very important aspect of pharmacotherapy of ARDS patient. So, what are the current evidence tell us about the role of corticosteroids in ARDS, and are there specific patients population or stages of ARDS uh, where they are most effective?
Thank you, sir, for the question. As Dr. Himanshu has elaborated in detail about the role of corticosteroids, he very well explained in a very crisp manner that although in ARDS patients, corticosteroids are being used, but it's still a subject of ongoing debate. The thing is, there are two places where we need to think about where we use corticosteroids. One is at what stage the patient is coming in. Say the patient is coming within the first for 24 to 48 hours, early stage, then definitely you should start the corticosteroids. As for we have seen in the Desai ARDS trial that showed that if we have early initiation of dexamethasone, they started with 20 milligram for the first 5 days, then tapered to 10 for the next 5 days. So in those patients, those who presented early, they had reduced mortality and like they had more ventilator free days. They had improved ventilator free days. So one is early stage, and the next is the grading of the ARDS. So in the recovery trial, which was done in 2020 on COVID-19 ARDS patients, that showed that in mild COVID-19 patients who did not require oxygen support, if in them dexamethasone caused more harm than good because it led to secondary infections, and it also led to hyperglycemia, uncontrolled blood sugar levels, secondary infections with mucormycosis that became a rampant problem, leading to death due to the dissemination of fungal infections. So, as per the recovery trial, we should always give corticosteroids in the moderate to severe cases. Those are either requiring oxygen or ventilatory support. However, again, I would like to say that these studies have been done on a particular population, and these findings we cannot generalize to all forms of ARDS that come into us. So mostly when there are immune system is on hyperdrive, like hyperinflammatory ARDS. In those cases, corticosteroids will have a major role. However, in cases where the immune system is not in overdrive, corticosteroids might not be much helpful.
Yes, very rightly said, Dr. Swadip. Any specific agent or, as you rightly mentioned, that there is very specific diagnosis, specific etiologies we need to use, not to generalize it in every cases. In pneumonia cases specifically, do you want to throw light in which pneumonia cases we use, and in which other pneumonia cases we cannot use?
See, when you're suspecting a viral pneumonia and the patient has come in the moderate to severe cases, you should definitely start with steroids. Dexamethasone is the preferred choice. As the trials have suggested, dexamethasone has a good response. But if in cases of bacterial pneumonia, we should be very cautious, and we should preferably go in for hydrocortisone in the sepsis dose, uh, keeping in mind that the cause of the ARDS is bacterial pneumonia. So, along with high dose of antibiotics, you can maybe start on steroid therapy, but instead of going in full blown high dose of glucocorticoid, we can maybe start on hydrocortisone.
Okay, so it is the message is clear. We need to use in the early phase of the ARDS. In the later phase, it has a more disadvantage than advantages. Himanshu sir, you showed very nicely that picture of the that table. Can you tell us again? It was a very nice and precise message in that slide. When to use the steroid in ARDS? Yes, Himanshu sir.
Yeah. So that slide was from a trial which is published in ATS. So the main purpose was key when there is early ARDS, you should use the steroids. Am I audible properly?
Yes. Now audible. Now audible.
There is some issue, so please pardon me if there is
Yes.
some audibility issues. Yeah, my network is fluctuating. Shall I quickly go to my mobile network? Yeah. I understood. Just give me 1 minute.
So meanwhile, till Himanshu sir coming again, so the in steroid, as far as evidence is there, evidence of using steroid in ARDS is we need to use very precisely whenever there is ongoing inflammation. Even though with the use of our all strategies, when we have sedated the patient, we have relaxed the patient, we have intubated the patient, and even though after that patient is not improving means FiO2 or the FiO2 is not coming down effectively, and other parameters are not in favor of the pure infection. In that case, in those very selected cases, we can use steroid very precisely. Yes, Himanshu sir.
Yeah. I'm coming back. I will.
Sir, you have to log out from one of the devices. Only one device, please continue with.
Yeah, I'm ready now. Now, that table which I showed is from a counterpoint trial, which was published in 2021 in Chest Journal. So it gives us a very strong evidence that when the PF ratio is less than 200, and there are similar risks like COVID-19, so that time giving steroid is highly recommended. And if the complications from the steroids are very likely, then consider the steroid on case-to-case basis. Whereas if the PF ratio is between 200 to 300, if there is influenza-like illness or non-infectious etiologies, for example, trauma and rapidly improving PF ratio, it is better to not to give steroid at this level. The influenza is very notorious problem. The influenza itself can cause fungal infections even without steroids. So if we are diagnosing influenza as a problem, then it is better we avoid steroids very early in the beginning. So that was a crux of that table from a counterpoint trial which was published in Chest in 2021. That is
Yes, thank
very
you.
essential. In fact, that table can be put in every ICU.
Yes. Thank you, Dr. Himanshu sir. So the point is, so not in every viral pneumonia, only in specifically COVID pneumonia, evidence is strongly suggesting to use steroids. In other viral pneumonias, we need to avoid as far as possible. And in other selected cases, we can use after selectively checking there is no any specific infection and only inflammatory pathology is taking is the culprit of patient's worsening ARDS. At that time only we can use a steroid. And sir, any specific agent which steroid to use, hydrocortisone or dexamethasone or methylprednisolone?
It depends. Like dexamethasone was a preferred choice for COVID-19. If there are other inflammatory condition, if there is a sepsis, then hydrocortisone is preferred in a sepsis dose, which is a lower dose than the routine dose. Like what we use over here is a 50 milligram 4 times a day hydrocortisone. so equivalent to 200 milligram per day. So these are the steroids which are effective in ARDS. Methylprednisolone was used in a very older trials, but nowadays we don't use methylprednisolone that frequently compared to these rest of the two steroids, because the methylprednisolone again being potent in nature and a very bad examples of having bad mucormycosis during COVID wave. So we avoid these agents, the dexamethasone and hydrocortisone,
Okay,
two
thank you,
major
sir.
steroids.
Okay, so we'll go ahead. Now, there is growing evidence or interest in immunomodulatory therapies other than steroids in ARDS management. Can you discuss any promising agents or approaches currently under investigation, sir?
Yeah, absolutely. That is very interesting topic. If you all remember, the interleukin 6 was inhibitor. For example, tocilizumab was very used in the first and second wave of the COVID. So it blocks the cytokine storm, and multiple clinical trials have shown multiple different mixed results. Although the original molecule result was very disappointing, but again, the in real world scenario, we have seen that there was a good benefit with the interleukin 6 inhibitors. Similarly, there are a group of drugs like interleukin 1 inhibitor, which reduces the neutrophilic activation. They also have a limited data, but a problem with them is that it causes lot of immune suppression. Similarly, other groups like TNF-alpha inhibitor, they also reduces inflammation. But again, the present clinical status is again not recommended. They were used during the COVID ARDS, but nowadays we don't use it. I guess the stem cell therapies also have some role, but they are again very early in the trial. There are two molecules which are available with us are macrolide and statins. The macrolides have a very good anti-inflammatory effect, but again, unclear benefit, and we have a risk of resistance later in the life for the patient. Statins, I think the previous speaker has talked about statin. It has a very good effect on endothelial protection. Again, not clear proven benefit. There are some again similar molecule like ulinestin. They are on the similar backgrounds, which are under trial and were available in India. Interferons. Interferons are again, they are good antiviral, immune modulator. They are under study, but carries again bad side effects, including fungal pneumonias. JAK inhibitor. Again, going back to the COVID memories, JAK inhibitor were first introduced that time in the second wave of the COVID, like baricitinib. They also block the cytokine signalings. So they have a good shown good effect in real world in some cases, but have not shown a very promising result in clinical trial. Then complement inhibitors are also one of the group of drugs. Again, it is experimental. So by and large, if I can say what we can use in present days are macrolides, statins, and corticosteroids. Apart from corticosteroid, what we have available have tocilizumab, but again, it needs a very good evidence. In routine ARDS, there is not yet a very good evidence for that. So rest of all these drugs don't have a proper evidence.
Yes, so tocilizumab only in COVID patients and in specific group when there is an hypoxia and steroid we have used, and even though inflammation is not settling down, then only we should use. Otherwise, no any other in other cases we should go for it. Thank you. And so now, Dr. Govind, do you want to add about anything about Dr. ulinastatin, as you were interested to give the answer in the role of ulinastatin in ARDS?
Right, sir. So ulinastatin is again basically a statin only, the statin molecule which has been used and tried and tested in ARDS. So it has shown few benefits, particularly improvement in oxygenation, as well as there have been data, particularly a lot of data and meta-analysis from the Chinese group, wherein they have shown a mortality benefit by reducing the inflammatory cytokines. The only problem with this data is it's just driven by the Chinese group of studies. There are as of today, there are no much data particularly driven by the Western population, Western group of studies or the Indian studies. I have myself used ulinastatin in the management of ARDS, but to frankly tell into this platform of a CCI webinar where a lot of people are hearing and might propagate the practice. It is still maybe in a gray zone, and using it depends on I think case to case basis where we can try ulinastatin. There have been few data, particularly in ARDS secondary to pancreatitis, where it has shown some mortality benefit as well. So if we divide it as in part of an pneumonia-associated ARDS and those with the secondary ARDS secondary to trauma or due to pancreatitis, ulinastatin has shown some benefit with secondary sepsis and secondary ARDS, that is particularly with pancreatitis cases. So we have other such molecules also which are coming up. So probably with the given point of time, at this point of time, it's too difficult to say or to recommend the use of ulinastatin. As sir has spoken, I think corticosteroids do have a very strong role other than the invasive ventilatory and the non-invasive ventilatory parameters. So other than that, the rest of the pharmacotherapeutics are still not to be benefited, particularly in case of ARDS, or we cannot have a strong recommendation. Even the studies, multiple studies do show the same thing. So I think it's again in the gray zone, might be used in cases as patient to patient basis.
So thank you, Dr. Govind. So now another important topic, the pulmonary vasodilators. It has been studied in the historically quite well, nitric oxide and prostacyclin. So because theoretically, if we understand these two molecules are pulmonary vasodilators, and they improves the ventilation perfusion mismatch. But very lesser evidence there, and it's used in ARDS. What is the current evidence? Is there some point or positivity where we can use this?
So again, another very important molecule which has been used is the inhaled vasodilators. And at the current point of scenario, we have two molecules which were being studied. One is the inhaled nitric oxide, which made a lot of noise, including the ARDS clinical network data did show that the initial future investigational therapies that inhaled nitric oxide was being tried in most of the centers where the ARDS protocol was being managed. So again, we need to know the pathophysiology here. We all know that when there is an ARDS, which is a heterogeneous disease, it's not just the disease of an alveoli. There is the disease of the alveoli. The inflammation is also taking part in the associated capillaries and the blood vessels as well. So there is endothelial dysfunction happening. There is capillary damage other than that of an alveoli damage. So this part of the molecules, basically the inhaled nitric oxide or the prostaglandins, are basically focused on the vascular component. We all know how there is a VQ mismatch happening, how there is a shunting happening in case of ARDS. So the prostaglandins, particularly the inhaled prostacyclins which are being used, that is PGE1, have been shown that they improve oxygenation by working or acting on the cyclic monophosphate molecule and causing pulmonary smooth vessel dilatation or relaxation, hence improving oxygenation. But as of today, the initial study which was published, which made noise of bringing the prostaglandins or the prostacyclins into the market, was an RCT, which was a single center study. It showed that there was a 71% betterment in the oxygenation of the patients with ARDS when that compared to the placebo, which had 35% benefit. But at the end of the day, when there were systemic meta-analysis reviews done, none of the studies or none of these systematic meta-analysis have been shown that they have any mortality benefit at the end of 7 days and 21 days. Another important thing which has happened with prostacyclin E1 is that they are known to cause hypotension. Most of our ARDS patients are already having sepsis or already having septic shock, and a lot of times they do have septic shock associated as well as ARDS with cardiogenic shock. So in such cases, a drug which is being used basically to treat a problem, if it itself is causing an hypotension, is a big problem. So this has been one of the reasons of not being using prostacyclin E in the cases of ARDS. And again, this thing is probably get obsolete, or maybe a new modifications in these molecules need to be done. Number two, this prostacyclin E1 also acts on improving the right heart function, because at the end of the day, all this vasoconstriction, what is happening in the alveolar level, is affecting directly the right heart. So right heart pumping or the RV functional pumping improves oxygenation as well as improves the overall body and reduces congestion. So that is why this molecule is maybe or will come again as a repurposed drug in the future, maybe with some tweaking or some modification. Another important thing other than the prostacyclin E1 is the inhaled nitric oxide. Again, this works in the same mechanism, that is pulmonary vascular relaxation. The mechanism is just that the intrinsic nitric oxide synthase molecule works on the cyclic GMP, and in the end, it also causes pulmonary vasodilation. But again, this molecule was used very much enthusiastically in the past, has now again taken a back seat, probably because of the no mortality benefit which has been seen. So if I want to summarize it, again, these molecules are not shown to have any mortality benefit, hence cannot be recommended in the routine practice.
Yes, very nicely said, Dr. Govind. It was a very, very precise and very nice answer. Now, here from your discussion only, so it is very clear message. Yes, it is a vasodilatory effect, and because of this, it improves the hypoxia, but it has no any evidence to have an improved mortality, right? And another thing you said told that it leads to hypotension, and any critically sick patient which leads to have a hypotension also will lead to have an acute kidney injury or renal failure. So this is the very important side effect of these two agents if it has been used for a longer duration. But the important point is it improves they improve the hypoxia even for a transient period, but they improve hypoxia. So don't you think they might be, although they are not having a mortality benefit, so we cannot use it for a longer duration, but their property of improving hypoxia may have some role when we are having a patient on very severe ARDS and they are not having a improved oxygenation, when patients on FiO200 and highest PEEP or whatever the parameters we can adjust on ventilator, and even the patients are remaining hypoxic and they are on the queue of either on ECMO or on lung transplantation list. So because we are in the era of this ECMO and lung transplantation, we need to think this now. So can we use these two agents during the bridging of this therapy to improve the oxygen for a limited period of time when we are going to put them on ECMO or on lung transplant, and to maintain till this end point, we can use this, I think, these two agents. What is the
I think
what is
one
your
thing,
thought?
as you told, is most of the studies were there pre-ECMO era. So now with the advent of the ECMO, where we basically want us to have a bridge between the initiation of an ECMO and that of a management of ARDS, probably it will have some role because we are not talking about the mortality part. So that was the only reason why it was being taken a back seat. So if you're thinking of ECMO or in the future we're thinking of a transplantation, maybe in that short period of time, which we can use as a window, the prostacyclin inhalers or the intrinsic nitric oxide can have a good role. That's why I think again in the future investigational therapies, this has been having one of the greatest investigations and research has been ongoing, wherein we can see with the use of ECMO and previously before the use of ECMO, these molecules can have a better benefit.
Yes, yes, rightly said. So now we will go ahead, Dr. Swadip Mishra. So now there is a role of every day the role of precision medicine and the role of biomarkers and clinical trend of the patient. How will we use these biomarkers or precision medicine in guiding the pharmacotherapy decision in ARDS now or in the future? What is your say?
Thank you, sir, for the question. Currently, precision medicine is the new thing, and in every field of medicine, we are now going into precision medicine. This is based on all the research that has been done till date, and we are incorporating this into AI or machine learning, and combining both of these, we are getting these machine learning models, they are being integrated into the clinical practice. So these are helping us to guide on important decisions like when to start steroids, what dose steroids should be started, whether immunomodulators should be started. And as we saw during the COVID-19 times, the role of antifibrotics, to give or not to give. It was a very important question. So, should we give antifibrotics to all patients, or should we just wait and start it on patients who are having progressive fibrosis? So, all these important decisions are gradually being shifted from clinician only to a clinician plus a machine learning model. So, these are this is the future of the medicine is evolving, and we are going to like both of us, like the clinician and the machine together, are going to take decisions on the patients of ARDS and managing their treatment. The biomarkers are very important because, see, the concept of ARDS, as I was just talking about when we were discussing on steroids, hyperinflammatory and hypoinflammatory ARDS, the two phenotypes that are coming up very prominently. So, if you are diagnosing a patient as a hyperinflammatory ARDS, you straight away start steroids. Earliest, the better. And if it is COVID-19 ARDS, definitely go for it as early as possible. Then, if it's a hypoinflammatory ARDS, then maybe you just stick to your basics. You give the low tidal volume ventilation, you manage the fluids, and just give supportive therapy. And biomarkers, like Sir said, interleukin 6 inhibitors, which are being used a lot during COVID 19. So, interleukin 6, plasma protein C, and soluble TNFR1. These all biomarkers will also help to stratify the patients, and accordingly, we can personalize the treatment strategies. So, suppose the patient has increased IL-6 level, so maybe we start on tocilizumab without thinking twice. And definitely, the machine models are going to assist us as well in taking a decision.
Yes, yes. So very rightly said. So can we identify so which are the two phenotypes of ARDS, like hyperinflammatory and hypoinflammatory? Every time we say. So how can we identify this? This is the hyperinflammatory type of ARDS, and this one is the hypoinflammatory type of ARDS.
So when the patient comes in, we definitely we send her all the inflammatory markers. Mostly CRP is elevated. Then interleukin 6 is elevated. So based on these parameters, we know that there is an inflammatory response going on in the body. And at that time during COVID-19, we had a protocol of like day 0, day 3, we monitor day 7. We monitor the inflammatory markers. Are they on a rising trend or are they on a declining trend? So if they are on a rising trend, definitely using these biomarkers, we have a targeted approach, so that the earlier the better. ARDS treatment, when it comes to pharmacotherapy, is always the earlier the better.
Yes, yes. So very simply, if we tell the inflammatory type of ARDS will be having a very raised CRP, there will be more tachypnea, there will be more hypoxia, they can be having a hypotension. The patient might be in the shock. So these are the sets of patient. The ARDS patient, they are having a hyperinflammatory type of ARDS. And another patient, there is a mild hypoxia, work of breathing is not that much high. CRP or inflammatory markers are lesser in numbers, and they are relatively stable. They can be settled with a very minimal oxygen requirement. So they are the hypoinflammatory type of ARDS. So this we need to know. So now we will go ahead, Dr. Sindhura. So there is a role of and discussion about cell-based therapies in ARDS. Previously, it was also mentioned in historically, and in the recent last 5 to 7 years, there are some evidence which is emerged. Can you please throw the lights in stem cell therapy and mesenchymal stem cell? Is there have a role in ARDS management in present era?
Yeah, basically these mesenchymal stem cells are currently being investigated as a potential treatment because they have a ability to reduce the inflammation and promote the tissue repair. It can repair the endothelial and the epithelial layers, and it has potential to improve the lung function in patients having severe lung injuries because of ARDS. So there are a lot of clinical trials which are going to assess their safety and efficacy. Almost 13 studies I have went through, out of which 655 cases they have done, and most of the cases are usually post-COVID. During the COVID ARDS only was usually taken into consideration. And these administration of mesenchymal cells, the route of administration and the dosage of administration is still not yet clear. But these studies have shown a lot of improvement in the lung function, and survival of ARDS patients has also been shown good trials in these trials. But still further, however, still further trials are usually required. And the mechanism of action, how these mesenchymal stem cells, how they repair is by releasing various growth factors. They release growth factors, they release the cytokines that help to reduce the inflammation, and it protects the damaged lung linings, the alveolar lining and the vascular lining, endothelial lining, and they promote the alveolar fluid clearance from the injured lungs, and to a little extent it can clear the fluid collected in the alveolar near the alveolar layer, and it helps in promoting the oxygenation. So still there are a lot of challenges and limitations, and while the results are much promising and future research is still needed to optimize, to know about how to deliver these mesenchymal stem cells or to determine the optimal dosage, what is to be given. And we need to fully still understand the mechanism of action of mesenchymal stem cells in ARDS. So potentially two types of stem cells are usually used in ARDS research, mainly the EPCs, they call endothelial progenitor cells, and pluripotent stem cells like induced pluripotent stem cells, IPSCs they are called. So these two are the main type of stem cells which are used in this mesenchymal stem cell therapy in ARDS.
Yes, so very rightly said, Dr. Sindhura. So there is an latest evidence of 2023 meta-analysis. It has mentioned some positive results of stem cell therapy, because stem cell therapy is everywhere. Wherever there is no role of something, or there is no any evidence of something good we may give deliver to or not. In all these scenarios, stem cells are now are studied. So herein also, as you mentioned, rightly mentioned, stem cell therapy can be of autologous stem cell therapy, or umbilical cord based stem cell we will be utilizing, and whether to use by a tracheal route or by IV route, because ARDS is a lung pathology, so there may be a evidence, there may be some role in when you give in intratracheally rather than giving intravenously. So these are the things we need to check what is the evidence is coming up, but we need to definitely see whether because the latest evidence suggests some positive results, so we need to check where this in the future we might have some role of this stem cell therapy. Now we will go ahead and we will have to Dr. Himanshu sir. Now in the present era, we are in the era of artificial intelligence, and everywhere artificial intelligence we have to check. So ARDS, artificial intelligence role in ARDS management, it has been so much of noise, and it has been told, and it has been studied, it has been told by so many places in international platforms. So what is the role with the rise of AI and machine learning? Do you think these technologies will play a role in optimizing this pharmacotherapy for ARDS? If so, how? And whether we can implement in short period of time in India or not?
Yeah, great. Very fantastically designed question, and very essential for present era. So artificial intelligence, machine learning is coming in every part of medicine in a very big number. So definitely the ARDS, which is the most drastic disease, we have to get well versed with that. The primary we can utilize the artificial intelligence by improving the drug discovery, precision medicine, then dosing optimization, treatment response, etc., etc. First, I will start with the diagnosis. Early diagnosis and risk stratification. So how we can do? We can have good AI-based models, including the chest X-ray, CT scan, which can get inbuilt with the arterial blood gases. So we can find out the early ARDS in the ICU very further early than what we are finding by human itself. Then there will be a deep learning algorithm. For example, the ARDS from the other condition. For example, is like whether infective ARDS, non-infective ARDS, that can be learned with the help of the different AI tools, including the radiological surveys. For example, the ARDS due to trauma can present differently compared to the ARDS of the fungal infection or viral infection, depending upon the radiologies. Then next is going towards the drug dosing. So how much the AI can drive the precision dosing, like patient-specific variables. For example, depending upon patient's age, weight, RFTs, LFTs, what we have to do, we have to calculate all by all, and then we have to give it. So same thing can be done by the artificial intelligence very early. And then the dosing can be done. The reinforcement of the learning algorithm to adjust the dosing dynamically based on the real-time data. So this one important thing. Then the last Along with that is AI analysis of the serum drug levels. So suppose and pharmacokinetics. For example, if we are giving neuromuscular blocking agents, so if we can identify the an amount of drug and if it is going to cause further side effects, so we can stop or we can optimize the dosages as per the AI calculations. So that before developing a very good bad side effects, so that can be done. Then we can have treatment responses and outcome for likelihood of the drug responses. Depending on serially, we can do the X-rays. So depending upon the serial X-rays, the AI can tell us whether we have to stop the steroid at this level, whether we have to modulate the dosages. But then again, there will be challenges. So whatever gloomy it looks, there will be some challenges like data quality issues. For example, I will like to give you one example. Like a few days back, we have a tuberculosis AI implemented in one of our hospital, and suddenly the corporation people came and told that no, this is a tuberculosis X-ray. You have to start the tuberculosis treatment. And when we investigated further, actually it was a viral pneumonia.
Okay.
X-rays, we utilize too much of AI into initial radiologies. Then ethical and legal concerns will definitely be there. We have to utilize AI in very beautiful way. We cannot take it blindly. We have to take it as a challenge and then modify everything. So this is what my take, but it is very gray area presently. We have to go very fast on artificial intelligence to early diagnosis, precision treatment, and recovery of the patient.
Yes, yes. So rightly said. The point is, we all doctors need to be AI trained, and so how this AI works and how can we utilize this AI in our routine daily practice. And another important thing is we need to be very precise and careful in entering our data. If our data is entered very appropriately, and then AI will be quite useful thing for us in patient management. So now, and with the it has been told by at every platform that. With the proper documentation, this AI can tell us whether this from the beginning that patient whether we are dealing with the hyperinflammatory ARDS or hypoinflammatory or heterogeneous ARDS or homogeneous ARDS, and whether to give steroids at this point or not, whether to give this which kind of invasive ventilator therapy, and how much PEEP or how much or amount of these radiation awakening trial, at how much duration we can know with this AI implementation, and very precisely on very dynamic level. So AI will be going to change the trend in management of the patients of the ARDS within some time. So now we will go ahead. Now we will, as we have mentioned, talk about everything. Now we will go in little parts. Dr. Govind, vitamin C and D were out of the syllabus in the management of ARDS, but also in from the last 4 or 5 years evidences, vitamin C has come in the literature again. So, what is your take? Is there a role of vitamin C and vitamin D in the management of ARDS, and what is the latest evidence?
Yes, sir, absolutely. I think multivitamins have been a great role and great part in the management, both in OPD and in the IPD of our treatment. So on the lighter note, but seriously, vitamin D is something we still have a lot of data available, particularly in the management of a chronic lung disease. So we have seen that vitamin D has a role, and vitamin D deficiencies associated with a bad prognosis in COPD. It has a bad prognosis and bad management in asthma and also poorly controlled asthma, as well as in tuberculosis. So there have been a lot of studies published in vitamin D, particularly in the management of chronic lung diseases, including in the NEJM as well as in BMJ. We have a lot of studies with this. But when it comes to ARDS, there have been few RCTs and few trials which have been published. All these studies have shown that neither the deficiency of vitamin D is associated with poor prognosis in the management of ARDS, nor utilizing or usage of a vitamin D in the case of management of ARDS has shown to have any beneficial effect. So what I would like to summarize about vitamin D as of today's webinar is that we still don't have a very strong evidence, and still it is out of the picture in the management of ARDS. So vitamin D still has a very far-fetched reality from the management of ARDS, because the usage of vitamin D in all these studies have been very high. That is almost 5,50,000 or almost 6 lakh units of vitamin D. The daily usage of an RDA, what we suggest in most of the patients for a week, is almost 60,000. So imagine giving us such a high dose of vitamin D. We don't know whether such patients do have even hypervitaminosis D associated side effects. Coming to
Yes.
vitamin C, yes, it was used in the past. People are using in the present, and maybe in the future also we might see a lot of usage of vitamin C infusions in the management of ARDS, particularly even in COVID. Every patient was taking vitamin C tablets. So the role of vitamin C has shown great role, particularly that phenotype of patients with ARDS secondary to a sepsis, because sepsis and vitamin C have a role. We have seen that people with sepsis, there has been some mortality benefit with the usage of vitamin C. And this vitamin C has been used for almost 4 days, that is 96 hours, with a usage of almost 50 milligrams per kg over or for every 6 hours for up to 96 hours. So that's a long dosage, almost for 4 days, every day, 4 times, using 50 milligrams per kg of vitamin C. This is one of the study, which is, I think, VITASIS trial, which was one of the largest trial in the vitamin C management of sepsis and ARDS has been seen. Now, why this vitamin C has been showing such a benefit is in sepsis, particularly vitamin C through its multiple mechanisms by inhibiting the cytokines has shown that it also has been associated with the reduced usage of the vasopressor agents. So what has been shown is not the improvement in oxygenation, not the improvement in the mortality particularly, but by indirectly reducing the usage of the vasopressor. Like imagine that a patient requires 10 ml of noradrenaline. By the usage of vitamin C, it has been seen that the requirement of noradrenaline or the requirement of dopamine in such cases has been reduced. Now, why this is important is we also know that the long-term usage of vasopressors are associated with AKI, particularly the dopamine. So by reducing the usage of vasopressors, indirectly it is helping in the prevention of worsening of shock. So that is how that variant, particularly the sepsis variant of ARDS, have shown great benefit. It is not shown to have any great benefit with those of trauma-associated ARDS, pancreatitis directly associated due to the lipase and amylase causing ARDS. No, but in cases of bacterial sepsis and in case of viral sepsis as well, that including the COVID infection, vitamin C has shown some promising benefit. Probably we might see again this vitamin C being practiced in our. Why this molecule is been of a great interest is that the adverse events are very less. Now, when we compare with that of say cetraccurium or that when we compare of inhaled nitric oxide or a prostacyclin, why this molecule has been a bit of a promising is the side effects or the adverse drug event profile is less, and it has a very wider therapeutic index when compared to the other narrow therapeutic agent molecules. So maybe that's why, if it is not causing any harm, why let's not try it and see that whether it causes any benefit, particularly the sepsis with the hypotension or the usage of vasopressor variant type of ARDS patients might be benefited with this, and maybe we might see again this in the future.
Yes, very rightly said, Dr. Govind. So, also this vitamin C in IV form in the sepsis patient, not a oral form. And you rightly said vitamin D deficiency leads to have a more ARDS, more exacerbation of respiratory pathologies. So, we need to treat vitamin D deficiency, but by treating vitamin D deficiency, we don't have any mortality benefit at all. So vitamin D not at all, but vitamin C some role or IV. Whether though at present sepsis guideline doesn't recommend also vitamin C in septic patient, but there is some evidence and we might see in the future. And so now we will go ahead. Dr. Swadip, do phenotyping of ARDS, hyperinflammatory versus hypoinflammatory, influence the response to pharmacotherapy? Simple, very answer, yes or no, and one line answer only.
Sorry, I was mute. Yeah, so definitely phenotyping is very important because as we just discussed a few minutes back, what is hyperinflammatory ARDS? There are higher levels of inflammatory markers, IL-6, IL-8, TNF alpha, CRP, everything is elevated, high blood count levels, lactate levels, either a use of vasopressors, and these are mostly associated with your sepsis, pneumonia, And the mortality is higher in your hyperinflammatory ARDS, almost 40 to 50% mortality. Whereas hypoinflammatory is a milder form. There are lower levels of inflammatory markers, then less use of vasopressors are required, and mortality is around 10 to 20%. So, why phenotyping is important? Because we need to quickly classify the patient, what kind of ARDS it is, and accordingly we start the treatment. So corticosteroids are mainstay for hyperinflammatory, as we have seen in the Desai ARDS trial. Then we can scale it up to immunomodulators like IL-6 inhibitors, JAK inhibitors. Then mesenchymal stem cells also are being tried upon. Then definitely prone ventilation, high PEEP. We have to like saving the patient is more important, and for that stratification, whether the patient is in a hyperinflammatory state or a hypoinflammatory ARDS is very important, because hypoinflammatory you have more of a conservative management. You have to dry the lung to prevent pulmonary edema, and fluid therapy, fluid management is very important. Just continue with your LTVV and corticosteroids. It has been seen in the ARDS net trial that corticosteroids have low to almost nil mortality benefit when it comes to hypoinflammatory ARDS.
So yes, so the answer is simple. Yes, we need to know whether we are dealing with the hyperinflammatory RDS or hypoinflammatory RDS. Now we will move ahead, Dr. Sindhura. So now we have covered the inflammatory phase of ARDS. Now after inflammatory phase, there happens a fibrotic phase of ARDS, and so many people have mentioned there has been some role of antifibrotic. But evidence is still missing. So what is your say in present era? Is there a role of antifibrotic? Because we are a pulmonologist, so we need to know and we need to tell the world or non-pulmonologists, is there a role or not in treating the ARDS fibrosis? Dr. Sindhura, you are mute. Please unmute. Please unmute yourself.
There's no particular any randomized control trials in view of use of antifibrotics like nintedanib or pirfenidone in ARDS patients. So why should we use this antifibrotics in ARDS? Is there any benefit? Yes, definitely. Antifibrotics may be effective used within the first week of ARDS is usually mentioned in few of the articles. And some patients with ARDS may have residual long-term lung function impairment. So even such patients also would be little beneficial, at least with the use of antifibrotics in few of these studies, like the Trinetics study, which has been done around 66 different hospitals around the world, most probably in the South Asian countries. So in that trial, they have shown that patients who are on nintedanib or pirfenidone post-COVID, so everything is mostly the etiology is COVID. COVID ARDS patients have shown no further reduction in FVC, or they had good 1 year mortality. The mortality was also a little reduced for the first 1 year post COVID ARDS. So there are a few studies have shown little benefits, but why antifibrotics might not be used in ARDS? Because the few etiologies, depending on if it is a influenza, ARDS, and all, they usually don't require antifibrotics during their recovery phase. Usually, they recover in a faster phase when compared to the COVID ARDS. So, and also it depends on the phenotype, whether it is a hyperinflammatory or if they have any inflammatory markers or cytokines further causing fibrosis. So, in that situations, maybe you require to use the antifibrotics. So these such strategies may even sometimes lead to over-treatment. So in case of some ARDS patients might have other associated complications. So you need not add up extra drugs even if you don't have evidence that when they are useful, maybe you can avoid adding the extra drugs or over-treating the patients with ARDS where there is no evidence available.
Yes, so the message is clear. Whenever there is no any stimulus of fibrosis, there is no any use of antifibrotics. So ARDS itself is not a stimulus for progressive fibrosis. So simply we should not use antifibrotics here. Now we will go ahead very fast. Dr. Himanshu, sir. So, as we are talking about the pharmacotherapy of ARDS, we need to touch the anti-infectives also in ARDS management. So, how do we approach a pharmacotherapy in ARDS patient with comorbidities like sepsis or COVID-19? And are there any special consideration?
Okay, so I will be very short. I will give a very short
Very short.
answer. Sepsis, yes. Steroids and good antibiotics. Anticoagulation, good antibiotics mean broad spectrum antibiotics, considering both gram negative, gram positive. Anticoagulations, if inhaled nitric oxide available, yes. Neuromuscular blocking agents, yes. If the ARDS PF ratio is below 150, definitely, and fluid conservation. These are the things which I will like to go for the sepsis. Reason is polypharmacy is very dangerous. Sepsis, already the patient is in a very bad shape. There will be many organs involvement, so I will restrict myself to selected antibiotic, steroid, anticoagulation mainly. Whereas for the COVID-19 nowadays we don't see any scientists, but along with this, I like to add remdesivir, particularly for COVID-19, to the present, like for steroids, good antibiotic, remdesivir, and anticoagulation. So this is what I will like to give to my two groups of patients which you have asked for.
Okay. So, thank you. Now, we will go further very fast. Dr. Govind, antibiotics as immunomodulators for potential pharmacological approach for ARDS. Very shortly and very fast.
I would like to be very short with this because already I think Dr. Himanshu sir has spoken about this.
Yes.
So, lot of molecules, particularly antibiotics, have been tried and tested in the immunomodulatory effect action in the management of ARDS. Particular interest molecules are the macrolides. We have the tetracyclines. We have even the oxalidinediones, that is particularly linezolid and fluoroquinolones. I think even fosfomycin have been tried. Out of this, the latter part, that is the use of fosfomycin, fluoroquinolones, as well as linezolid, have not shown particularly any great benefit in the management of ARDS. Now, what is very interesting is if it's a case of a bacterial pneumonia, particularly an ARDS, which is caused by an atypical infection, here both the antibiotic usage of the drug as well as the immunomodulatory action can be seen. So particularly, we have seen this with macrolides. So most of our practice, when we see the management of the ARDS patients, we see one antibiotic which is broad spectrum covering both gram positive, gram negative. Then we have an atypical coverage, either it is an azithromycin or a doxycycline. So this is most of our prescription. And sometimes if we have a suspicion for even a viral pneumonia in this picture, we add a fluid. Then as per the reports or maybe the culture reports, we slowly de-escalate. This is how most of our ICU charts will be in most of the hospitals. So here the macrolides and the tetracyclines, particularly the doxycycline molecule, have shown that either by inhibiting the toll-like receptors, which are one of the major receptors for the bacteria to adhere to, and then the whole cycle starts. That is, the inflammation happens, then there's a ARDS happening. So when it inhibits that toll-like receptors through which the bacteria basically enters inside, particularly the gram-negative bacilli, so it has a great role because it inhibits and causes certain immunomodulation. This is one mechanism. Other mechanism, we also know that azithromycin has its effect on even the innate immune sense, including the mucus barrier. So we know that the natural barrier starting from the nose till the airways is that the mucus. So if this mucus rheology is being maintained more thinned out, so it helps out in bringing out the mucus more easily. This is the mechanism why we even use it in cases of bronchiectasis and COPD, the macrolides, particularly the BAT trial where azithromycin has been used. So same mechanism has been shown to have some benefit. Again, no strong evidence, so cannot be recommended in all the cases. But where you suspect an atypical pneumonia, probably it's going to have a win-win situation. It's going to manage both the ARDS as well as probably it's going to manage the primary source of cause. But if it's a viral pneumonia, it's a big question again. Whether it's a fungal pneumonia, do you want to add these drugs and again make a burden for the patient by causing more side effects? Is again, I think, which has to be on a patient-to-patient basis. Same applies to even tetracyclines. It has been shown to act on the caspase-1, which is one of the important molecule for the apoptosis of the neutrophils. Because if the neutrophils are working haywire, they're damaging by the mechanism of neutrophil elastase production. So by inducing the apoptosis by acting on the caspase-1, the cells which are not required are to be removed out from that ARDS component. So in that way, even the tetracyclines have shown. So if to summarize, I think tetracyclines and macrolides have some role, still not something to be recommended in all cases, and should again be on a case-to-case basis. A lot of gray areas in our discussion today.
Yes, very rightly said, Dr. Govind. So, not a recommendation, but yes, by knowing the uses of these drugs, how they do this, we will be thinking there is no loss to use in atypical infection or a bronchiectatic patient or some set of COPD patients. Right. So, Dr. Swadip, now over to you. Very practically, as a clinician's view, what are the challenges you feel a clinician face in implementing pharmacotherapy called ARDS in real world practice? So it will not be a very book answer. It should be your thoughts in implementing
Yeah, thank you, sir. So the very fact that ARDS, acute respiratory distress syndrome, it's not a single disease, it's a syndrome. So you cannot have a standardized treatment for all patients. Many a times when the patients come in, they are referred from multiple hospitals from 1, 2, 3. So by the time they come to us, it's already delayed. So delayed recognition, delayed diagnosis, delayed treatment. That is one major problem. Then, as we have all been discussing this evening, there is limited evidence for pharmacological therapies. The pharmacological therapies are there, but then everything is experimental. Nothing can be stamped that this is the definite treatment of choice for this type. We have heard about corticosteroids being used in trials, but then they have not been generalized into all types of like non-COVID ARDS or all types of viral ARDS. Then adverse effects of all the medicines that we have been discussing today, like steroids have, they cause hyperglycemia, they have their own panel of side effects. Then immunomodulators, then beta agonists, all these medicines, all the pharmacotherapy that is available, those have a lot of adverse effects as well. And most importantly, in a country like India, resource constraints in low resource settings, access to advanced therapies like inhaled nitric oxide or ECMO or the newer drugs, experimental drugs, all these are they cause a big dilemma in the treating physician's mind when they deal with a case of ARDS.
Oh, yes, thank you. And now, Dr. Sindhura, now there was a role of beta 2 agonist and statin in ARDS patient previously. Now, it was very clear now in the last few, I think 15, 16 years that there is no any role. But there is some evidence is now growing up about using of these beta 2 agonists, the statins and beta 2 agonists plus inhaled corticosteroids combination therapy. So what is the present evidence? Should we start using these things now in managing ARDS?
So normally beta 2 agonists, they are not much effective in treating ARDS if they are used isolated single drug. Because they usually facilitate the fluid clearance and reduce the lung permeability, and also this is a theoretical advantage, but practically in few studies there are no reduction in number of ICU day stay or mortality wise. There is no much benefit is usually shown. And there are few studies like BALTI-2 study in which they have seen beta 2 agonists along with inhaled corticosteroids, they prevent progression of ARDS. So these studies are usually supporting not an isolated single beta drug agonist, or in combination with steroids, they might be having little benefit when compared to be given individually. So this is regarding the beta 2 agonists. And coming to the statins usually they are considered because of the anti-inflammatory effect. So these anti-inflammatory properties of these statins might reduce the ability to modulate the immune response in the ARDS is usually predicted. But even this has shown some inconclusive findings, and in a lot of clinical trials of using statins in ARDS have produced mixed results, with some showing no significant benefit on mortality or even ventilator duration or number of days in ICU stay, while others suggest a potential benefit in specific subgroups where it is a hyperinflammatory type, where depending on the phenotype again. So if it is a hyperinflammatory type, statins are of little help. When it is a hypoinflammatory type, statins didn't show much effect. So phenotyping or subgrouping of the ARDS would help in future for pharmacotherapy. Maybe some drugs can be used for different types of phenotypes.
So at present also there is no any recommendation of using this beta 2 agonist or SABA or salbutamol or a statin. So what about, but there is some talking of using this SABA plus ICS, means our means astalin plus budecort or LABA plus ICS in treating ARDS. Because there are in some literature it has been mentioned that this might have given some positive
steroids will have anti-inflammatory effect, yeah.
Yes. So what is your say in that thing?
Yeah, combination of beta 2 agonists and inhaled steroids, they definitely had little benefit when compared to using only the isolated bronchodilators.
Okay, but still
It is recommended.
Okay, but there is no still clear-cut recommendation, right?
There is no recommendation.
Okay,
but it showed little benefit when compared to using it alone, only beta 2 agonists.
Okay. So now next to Dr. Himanshu sir, there is some evidence about using GM-CSF, interferon beta 1 alpha and surfactant therapy in ARDS. So what is the evidence and can we use this now in present era?
Yeah, GM-CSF have some evidence it can improve the lung immunity and may enhance the recovery because there is it enhances the alveolar macrophages function and then it reduces the epithelial injury. Ultimately, it reduces the epithelial injury. But this is with very, very big caution because if it is a hyperinflammatory ARDS, this can worsen the situation. So hypoinflammatory, this can be used in adult only and only. So surfactant, definitely it is only neonatal, not even children, neonatal and adults, 0. Interferon, you asked interferon, na? Interferon, last one was, na? Yes. It also has some benefit in viral ARDS, but again, no consistent mortality benefit. So again, it is with out of these 3 molecules, I will go for only GM-CSF, that too into hypoinflammatory.
Yes. Okay. So now, Dr. Govind, what are some common pitfalls or misconceptions in pharmacotherapy of ARDS that you have encountered, and how do you address them? Very experience-based answer and very short, please.
Right. So again, so as I already discussed, the multiple prescriptions or the in the ICU when we go to manage this case of ARDS, the first problem which we have is that we don't know how did it start. So whether it is a bacterial pneumonia which led to an ARDS, whether it is a viral pneumonia which led to ARDS, or whether it is a fungal pneumonia, or whether it is a secondary ARDS secondary to some other organs. So I think one of the important misconception we have is when we involve multiple specialties, everyone thinks it in terms of their own point of cause being the reason. Like in a case of a CLD or a pancreatitis, when the patient develops a system like an ARDS, first thing they think is it is because of pancreatitis associated ARDS. Now, a patient with pancreatitis history can develop a bacterial pneumonia, and likewise, a patient who has a history of a COPD can develop a pancreatitis associated ARDS. So most important misconception, and I think the also solution which we need to do is as early as possible try to find out what is the primary cause which has led to ARDS, because a lot of time prognostication of a case of ARDS is being matters, and what stage of the ARDS the patient has come to us is very common. The second common misconception which we normally see is the usage of steroids. We know that early steroids usage has been shown to have a great benefit, particularly in ARDS secondary to viral pneumonias, that of a COVID also. But if we use steroids in the later stage of ARDS, it has shown to cause increased mortality as well. So I think usage of steroids is very common practice in ARDS, and we need to see as onto what is the day of ARDS, to take a long prolonged history, try to follow, because in tertiary care hospitals, what happens is most of the time these patients have come up or been referred from a nursing care setup or from a different place where they have been taken care. So we really don't know at what stage of ARDS we are actually managing these patients. So whether to give steroids or not. maybe we might have to face a lot of debate from the fellow doctors in our hospital, including the intensivist as well. But we need to sit back and see starting these patients on steroid, is it a worth and a valid explanation?
Okay.
So I think these are the very common misconceptions which we commonly come across in case of management of ARDS, particularly the usage of steroids. The rest of the things, I think, are something which we can actually manage. Anyone else, I think, sir, do you want to add anything to it?
No, I think you covered very, very well. So now, thank you, Dr. Govind. You answered very well and very nicely. For a shortage of time, we will go a little fast now. Dr. Swadip, with the emerging concept of precision medicine, do you foresee a future where ARDS treatment will be more targeted than a one-size-fits-all approach? You wanted
Yes,
to
sir, absolutely,
give the answer.
absolutely. Absolutely. The future of ARDS treatment is precision based medicine, because these AI based models and these blood based cytokine profiling and phenotyping, they will give us like within a narrow time frame, they will give us like what kind of a patient we are dealing with, what type of ARDS it is, what are the inflammatory markers that are elevated. So definitely the future of ARDS treatment is machine based or a precision model medicine, and this approach will likely reduce the treatment failures and like enhance the patient outcomes, improve the mortality. So yes, absolutely.
Okay, thank you, Dr. Swadip. Dr. Sindhura, looking ahead now, the trend of the developments of the research in ARDS, what do you think what do you think will be the most significant breakthrough in pharmacotherapy for ARDS in next 5 to 10 years?
We have a lot bucket list of drugs available, and we have to need to focus more on the potential to identify biological phenotypes of the ARDS, like homogeneous, heterogeneous subtypes, radiological, clinical phenotypes, and all. So hyperinflammatory, hypoinflammatory subtypes of ARDS. So more focus is needed on to identify the biological phenotypes, and then depending on that, we have a lot of drugs available, and maybe the precision medicine will target more specific therapies in future for treatment of ARDS.
Okay, so I think stem cell therapy, then
Stem
GMC
cell therapy.
might have some role in the future, right? And
Yeah, they are more positive than compared to the other things. Epithelial channel, endothelial channel, anticoagulants, and carbon monoxide. Mesenchymal stem cells are more promising results. Surfactant, interferons, and immunomodulatory drugs.
yes, thank
So
you.
we have to look forward.
Yes. Okay. And last, Dr. Himanshu sir, can you want to share a case where pharmacotherapy made a significant difference in your experience in ARDS patient's outcome? Any one nice case you want to share?
No, I will be very short on this. I remember only one case during that first wave of COVID. We used tocilizumab and patient improved dramatically. That was in the first wave, only first wave. But again, it made me very upset in the second wave. Tocilizumab didn't work in the second wave. So it is all very, very variable. And still we are learning about the pharmacotherapy. The best therapy is the ventilatory therapy, good antibiotics, and very low dose of steroids. These are what the pharmacotherapy presently. Again, as Sindhura said, Govind, Swadip, all discussed, there are so many drugs, so many new things will be there, and we are very hopeful about it. A very dreadful thing this ARDS is, and we need to be very on our toes for this, and we need to come together, everyone, and
Yes.
find out some good
Thank you, sir.
pharmacotherapy for. Thank
Thank
you.
you, sir. So I will like to share my one case of polytrauma ARDS. This was the case of our young fellow, our neighbor only, and he had a very tragic accident and a polytrauma on ventilator, and patient was improving. And on the sixth or seventh day, he suddenly got ARDS, severe ARDS, and a rapid increase in oxygen requirement, and FiO2 raised 200. And seeing the trend of its progression, it was only and only inflammatory type of ARDS, because there was no any sign of any infective. And so already empirical our antibiogram targeted antibiotic therapy was going on, but we were very, very clear that this patient was also near to us, and we wanted to do something. And seeing this, we thought that this is an inflammatory type of response, and this is repression is person because of inflammation only. We gave him a steroid of 24 hours only, of 120 milligram of methylprednisolone for 24 hours, and patient improved drastically. Within 30 hours, his oxygen requirement was reduced to 40% again, and patient was weaned off ventilator in next 4 or 5 days. So this was a very nice case in our memory, and we are still seeing that patient comes to meet us, and we are happy seeing him alive. So thank you all panelists. It was a very nice discussion. At the end, from one single liner from each one of you, starting with Dr. Himanshu sir.
Abhishek sir, you did a fantastic job. It was a very tough thing, and you did a really great job. And all the other panelists are so well read. Fantastic. Kudos. Thank you.
Thank you. Dr. Govind, anything?
Yeah, really, Abhishek sir, you did a very great job in moderating this wonderful session with a lot of gray areas. So my only take-home message is that I think we all need to focus particularly on the initial cause of the ARDS, because a lot of times the management of ARDS changes according to it, and even the prognosis as well. So I think that's something which we need to carry. And obviously in the future, we have a lot of molecules coming up, and we are all hopeful for the same. So thank you so much for giving this opportunity to be among with all the wonderful panelists with me and the moderator as well.
Thank you, Dr. Swadip. You're muted.
Yeah. So thank you, Abhishek sir. It was a wonderful session. Like all the panelists, I got to learn so much from every aspect of ARDS. ARDS is, as Dr. Govind rightly said, it is a very gray area, the topic we were addressing today. So there's nothing written in stone, like anything can change anytime. A new trial might come out tomorrow, and whatever we discussed today might either be enforced or maybe rejected throughout. So yeah, the future lies in integrating all the data, all the research and precision-based treatment. So yes, it was a very enlightening session. Thank you so much.
Thank you. Dr. Sindhura.
Thank you, Dr. Abhishek, first for organizing such a good thing without any conflicts, because we usually have conflicts with our critical care ICU people every day, whether to start steroid or not, and they usually don't accept whether we want to start or not. So, and one of my case experience during the first COVID wave was one 23-year-old patient had a cytokine storm, and CRP was 550. And his total counts, everything was so normal. Even before it was recommended to give steroids, I have given steroids in him. I have saved him, and it's very nice to see him coming back with his wedding invitation. I thought we lost him. He was on 100% FiO2. Even before steroids were recommended, I have tried using steroids because only depending on the CRP.
Okay. Yes, sure. So thank you all. Any question from the audience? So can we conclude now? Okay. So with this, thank you all panelists, and thank you CCI. Good night.